Good afternoon. I hope you're all enjoying yourself. We had a great morning, some very great speakers. I hope the breakout sessions went well for you, and I can see there's lots of networking going on. That's a great thing about these events. It's a chance to meet people, like-minded people, and share interest and talk about what each other's doing and so on. So we're moving now into the afternoon plenary, and the topic for this next session is access to healthcare. And I'm just now going to introduce the moderator and hand over to the moderator, who's Priscilla Lynch. Priscilla is an award-winning medical and health journalist with over 16 years' experience covering the sector. She's clinical editor of the Medical Independent, editor of Update Clinical Journals, and editor of Nurse CPD and Doctor CPD websites. She also freelances for a number of national newspapers, Medscape UK, and is a regular contributor on healthcare news on the radio. So I'll hand over and welcome Priscilla. Thank you.
Thank you very much for that lovely introduction, David. And thanks everyone for joining us this afternoon for our plenary session, which is on access to healthcare. So the topics we're going to look at today are health system resilience, climate resilience, mental health, well-being, conflict, migration, COVID-19 and the Ukraine. So a lot to get in the next session. Now, our diverse panel today brings together expertise from a wide range of areas such as mental health, disability rights, leadership and public health. And the focus is going to be on strengthening health systems and making healthcare accessible and equitable to all. So obviously a very worthy panel discussion today. So please welcome our panel, which are Dr. Julian Eaton, who is Mental Health Director of CBM Global. Thank you. We have Pamela Molina Toledo, who is from the World Federation of the Deaf. And we also have Dr. Margaret Fitzgerald, who is a former National Public Health Lead on Social Inclusion and Vulnerable Groups for the HSE. Apologies also from two panellists who were unable to make it, Dr. Ahmed Shadul and Dr. Trish Scanlon, who send their apologies. So first to our panel. Margaret, you have had a very busy few years with the COVID-19 pandemic, which is, I think, the ultimate challenge to resilience and access to healthcare globally. So can you just tell us a bit about your experiences and the biggest challenges that COVID-19 put on our healthcare system in Ireland, globally, and I suppose what lessons have we learned from the pandemic?
Maybe it's not quite working. I think, first of all, I was working within the public health family in the HSE for many years after I had worked overseas, and in between times I'd also gone out to different scenarios and situations, and the most recent major one was the Ebola crisis, and I was given permission to go to Liberia in 2014, and I learned a huge amount from that. So I moved into the social inclusion space in 2017 when the pandemic, when we first got wind this was going to be something major in January 2020, we knew that what was happening generally would not suit our groups. So the mainstream TV, the mainstream radio, the mainstream media, I say our people don't watch RTE News. So the first thing really is, based on what I learned in Liberia as well, was people need to know what to do to protect themselves, because at the end of the day with Ebola, it was the community in Liberia that fought Ebola by very basic infection prevention and control and isolation. So the first thing we had to say, do we know our groups? We knew there was a mainstream response, but our groups were outside the mainstream. Do we know who we were? Well, from social inclusion, we knew we were working with a lot of socially marginalised travellers, 35,000 in our country, 0.7% of the Irish population, very poor health indicators, a Roma community very hidden, 5,000 plus, very poor health indicators. Our homeless, up to 10,000 of our population living in homeless accommodation, women affected by domestic violence, and we knew also the huge numbers in direct provision. We knew a lot of these people would be at risk. We also had a sense, but not really until we were well into the pandemic, that ethnic minorities would suffer. So a key strategy from our end was to get the information to the people in a format that they could understand, in a language that they could speak, and then draw on the community resources, particularly the NGOs, and NGOs that were working with the vulnerable groups, because the government outsources a lot of its frontline support to the NGO sector in Ireland, which is not quite the same as in other European countries. So we had a multiple constituency, a very vast constituency. And the thing about it is that you had to be flexible, and you also had to think about different pathways for different people, and not one size fits all. People Mission Cara mentioned it earlier. So bespoke solutions, and there was no time to waste. So a few of my mantras were adopted from Mike Ryan, actually. Perfection is the enemy of the good. We have no time to waste. So in terms of how the most vulnerable were supposed to manage with this virus that required you to have strict infection control, hand washing. At that stage also, social distance was huge, and face masks. How do you tell somebody to isolate if they don't have a home? How do you tell somebody to isolate if there are 7 in a room? If they don't speak English, how do you contact trace them? So the HSE system had to be redesigned and reconfigured. So there were many wings. So if social inclusion and our people had to work across and between groups, within HSE, without HSE. So my key role was, in fact, to bridge the gap between orthodox or mainstream public health and then social inclusion family. And that was the big task.
Thank you. I suppose that highlights really that in Western Europe, people might think wealthy societies, we have good access to healthcare, but actually there are many marginalised groups that do struggle to access healthcare, and how do you reach out to them? So that you obviously learned lessons from your time in sub-Saharan Africa that could be applied to the Irish and to the European context there. Just the most basic things about how to communicate with people, how do we reach out to people to make them come forward? Because as we know, it's people who are in the lower socioeconomic groups who suffer the most and who struggle the most to access care and have the poorest outcomes. So there's been a lot of learning, I suppose, really from COVID-19, both home and abroad. And I do know, obviously, when you managed to reach out to those marginalised groups in Ireland, I suppose we turned to look at other countries where they didn't have access to the most basic, whether it was going to be testing, access to vaccines, to isolation. And the pandemic does continue, as we know, for us in the Western world. We are living with COVID, as we call it, but in other parts of the world, they still aren't there yet. Pamela, I'm going to come to you now, because I know there were specific challenges as well to perhaps the deaf community and other communities during COVID-19, particularly even with the wearing of masks and how to communicate to the community. Do you think, again, that there was valuable lessons that have been learned there, and that there were certain things that could have been done better?
Well, first of all, thank you very much. Thank you for the Global Health and the CBM, Irish Global Network, for making this possible for me to be here and meeting all of you. And I want to thank also you, Priscilla, and my esteemed colleagues here. When the COVID-19 pandemic first started, the government did reports, and they acted pretty quick, but they were not inclusive. They were not inclusive, which means the information they were putting out was not accessible. It wasn't accessible for the deaf community, and it wasn't accessible for a lot of people with different disabilities. Therefore, without that accessibility, what happened? sign language interpreters had to record themselves, right? They informing them about the mass of social distancing within the community, right? And asking people what to do. So it was a community effort, right? The personal assist, it was like a personal assistance. How do we go to the bathroom and wash our hands? And how do we do all of this without now with the social distancing? And especially we can't touch anything. So all of these barriers just showed up. The personal assistance of people with disabilities were cut off, right? Because they had to quarantine, they had to stay in their homes. So the community itself, deaf community, had a lot of communication barriers. So the deaf community, right, it's an intersectionality identity, which means the deaf community themselves belong to the disability organizations. And we have our individual rights. Therefore, we have our individual rights with the CRPD and the conventions of the CRPD or people with disabilities. So we have those rights. However, the deaf community also belong to the cultural and linguistics, quote unquote, minorities. Which means we have a collective rights of oppression by being colonized and community and cultural as well, and the linguistics deprivation as well. Now, the collective rights as a cultural linguistics community was not protected. We were not protected. We didn't have the human rights that we deserved. So the people, like indigenous communities, people from the African descent communities, they have laws that will protect them socially. But the deaf, we did not have these rights. Now, that was the gap, that's a huge gap right there. Now, confronting COVID, a lot of these governments forgot that because we needed to have this additional language for information, for the prevention, the care, the measuring of the health care, how to provide them attention. All of this was missing. Those were the gaps that were missing. Most of the governments did not put sign language interpreters. And when they did it towards the end, it was only at the national level. However, regional, local, or there was no sign language interpreter, so there was no information being filtered out. So deaf were left out on the cold to defend for themselves, right? And through social media, Facebook, Instagram, Twitter, what have you, they were recording themselves and sending this information. CODAs, Child of Deaf Adults, would also take them into social media to send that information to try to, and we would try to tell the governments that we needed sign language interpreters as well. Now that information, there was information as a care. However, the deaf people wanted, if they got sick and they wanted to go to hospitals, there was no communication there at the hospitals. And we went again, we would go back to zero. Access to, people having that access to, and continuous access. But we always have that communication barrier all the time, every day. We do not have that. Going to the hospital once, no interpreters, lack of communication. The professionals don't have that communication skills to deal with people. The cultural, the language, appropriation within the environment is lacking. Like maybe infographic information. There was not enough to provide that information, to have that equal information that the deaf people needed to go get the health care that they needed. They had to have an interpreter, and a face-to-face interpreter. At that point, it would have been fine. The technology system was fine. But again, think about this. Technology system in the developing countries is not the best. in developing countries, deaf communities where people live in the rurals did not have access to internet or technology. Therefore, or the internet was spotty, and the information wasn't coming out. So COVID changed, everything went online, Zoom, what have you, but for the deaf people, again, it was a barrier. The internet, when they talked about the health, there was no access for the deaf. Therefore, there's still these gaps there. There's still these challenges. Now we are aware of this, and now we're fighting more for this and advocating more for this. And we need to empower also the deaf community and health professionals. They must work together within the deaf community as well, so that the deaf because the deaf have these expertise and can provide this information to the healthcare to help better serve us, the quality of service that we all, the deaf people, need globally. So training the deaf training the professionals, and working with the deaf community and at the local level with the hospitals that are locally, so that we can reduce that stigma and cultural bias that exists, and we can focus on the deafs and not the audist, but focus on the cultural, the visual language, and the community. So I guess that's kind of a summary of your question.
Thank you, Pamela. Some very salient points there. I think you really outlined very well, I suppose, the challenges for your community and for the larger community of those with disabilities who felt very invisible during the pandemic. And it wasn't just about access to physical services, it was about communication, knowing where to go, how to understand, and I suppose being an afterthought really in pandemic planning. So that there's a lot of lessons that we can learn from COVID-19 to have these things in place for the next pandemic, not if, it's when, so that we can immediately reach out to those who do have additional needs and make sure that their voices are heard and their access is there from the very beginning of services. And as you pointed out as well, there is technological solutions that are on the way and that we've kind of learned a lot about. They're not going to answer everything, but that we need to have these services in place. And obviously those with disabilities were the most cut off during the pandemic. Their services were stopped and it was very hard to get them started again. And I suppose they felt very isolated. And I'm going to talk to you now, Julian, I suppose really, because the mental health impact of the pandemic, really, how do you quantify it? Just on people themselves, people being cut off from family, from friends, isolation, fear. We're just beginning to look back now and be able to look at the studies and see about, mental health crisis, anxiety. It's just huge. So I suppose really, what are your thoughts, I suppose, on what's come out of the pandemic in relation to mental health and what do we need to learn from it?
Yes, you summarized really well some of the things that we realized, how essential community is, how important it is for us to be constantly engaging with the people around us. And it's something very specific, actually, about an infectious disease epidemic that particularly hit the thing that matters most to us in terms of our well-being. And I think I was working at the London School of Hygiene, and Chris Whitty, the UK's health chief, was one of our colleagues, and there's a really a real tension in the advice, very important advice, being given around separation of people, infection control, and keeping people isolated for very good reasons, and the point at which we realized the impact that was having on a population, and starting to think around ways of addressing that other kind of mental health epidemic that was happening at the same time. Just a very brief point about technology, actually. If this pandemic had happened 10 or 15 years ago, it would have been a very, very different thing. And actually, although, as Pamela said, it was imperfect, I think the opportunity for people to continue to actually communicate with their loved ones was enormously important, and we need to remember that, as well as some of the more formal telemedicine and telehealth type things that were put in place. So what have we learned? The response actually, on the mental health and psychosocial support side, benefited enormously from the lessons we'd learned from other epidemics, like we've heard already about Ebola in West Africa. I was living in West Africa and was very involved in the response in Sierra Leone, actually not Liberia. But there were some really important lessons that we did. Immediately after that, there was a piece of work the WHO did to draw lessons on the mental health and psychosocial support response in those 3 countries. And I think a lot of them actually had started to be embedded in the response in a few other places. And that meant that actually the mental health community responded extremely quickly at a kind of very high level. So that the WHO, I know they're coming for some criticism, but they learned some lessons very quickly around that. And there were already MHPSS resources that were then adapted for COVID-19 and really were available in weeks. And I think that had a huge impact. There was a children's book that was produced called My Hero Is You. I don't know if anyone's seen it, but that's been translated into more languages than anything other than Shakespeare, the Bible, and the Quran. And that's all happened in a couple of years. It's quite incredible. So actually, the mental health community, because of a 20-year history, we're a young field, but we've got a 20-year history of global mental health. And actually, I think it was possible at a high level to respond quickly in terms of resources and information. Where things really broke down was at national level, both in high and in lower income countries, where the systems were not ready and were not, that term resilient that we use. So it was only really in places, interestingly, that had some crises before themselves in country, where there was an efficient response to the mental health needs that populations had. But there's all sorts of different levels that we had to think about it. And we've talked particularly about vulnerable groups. And in some ways, our interest in a vulnerable group is people with psychosocial disabilities, people with pre-existing mental health problems whose systems completely broke down. Social, that they relied on, but also access to medicines and those very practical things, the visits to their counsellor, things that people really valued and found very supportive. But there was, of course, that other dimension of the wider population who maybe didn't have pre-existing mental health problems that had made them go to seek services, but actually developed problems during that very, very difficult time. And the response couldn't be beefing up mental health services at all. The big lesson we've learned from mental health and psychosocial support is everything happens in the community. What matters is your economic well-being, how well you're getting on with your intimate partner, if there's violence at home, whether or not you're able to send your kids to school and feel comfortable that you're doing your job as a parent. All of those things matter much more than mental health services. And actually, they're a bit intangible. So a lot of our work in mental health is actually about mobilizing things outside of mental health services to make them work better, whether it's community resources and structures, or whether it's housing, or other elements of an emergency response. So there has been an enormous amount learnt. In fact, in 2 weeks' time, we're going to be holding a workshop in Nairobi about the Ebola outbreak in Uganda at the moment. And that, I think, is going to be a very different thing than when we were scrambling around in the West Africa outbreak. Because actually, we've drawn upon an amazing group of people who've responded in all sorts of crises, including the West Africa Ebola outbreak. What an amazing resource that they're going to bring to their colleagues in Uganda for that outbreak that's happening now.
Thank you. And I know from speaking to those in mental health, there were some other lessons, I suppose, from the pandemic. How do you align mental health protection with physical health protection when you're bringing in major lockdowns and the impact that they can have on people's mental health, not just the spread of disease? So there's been a lot of things, I suppose, really that we have learned during the pandemic about that. And obviously, as you've mentioned, there are people with pre-existing mental health illnesses across the world. I mean, suddenly saw their services being shut down or very difficult to access, and plenty of people slipped through the cracks and would have experienced a worsening of their condition and would have ended up hospitalised, whereas before they would have been picked up and just about basic mental health access. So I think we have learned now that even across all countries, to try and keep those services open as much as we can, they're just as vital as physical health services when it comes to pandemic. I mean, it's all connected. And I suppose I'm going to ask you and Margaret really actually as well. It's not just about, I suppose, people and patients, it's about healthcare workers too. their mental health. You both have worked in very challenging situations in sub-Saharan Africa, and you've worked through the pandemic very much so. But the resilience of healthcare workers, because obviously without healthcare workers, we don't have a healthcare system. I mean, if you look at the statistics on after the SARS pandemic and now after the COVID-19, it's had a huge impact on healthcare workers' mental health. And it's not like they can stop and take stock now, because they're under massive pressure with record-breaking waiting lists in every country and trying to catch up from the pandemic. So I suppose, what are your thoughts about that? How do we ensure the continuing resilience of our healthcare staff against the backdrop of pandemics and huge waiting lists?
I remember at the start of COVID, the absolute fear in amongst the social and healthcare staff, particularly with those working on the front line with the homeless in the hostels, those working in direct provision. And I mean, we couldn't meet in person, so we're very conscious of burnout. And when I worked with MSF in Malawi in the HIV and TB program, we used to climb mountains and go off to the lake for picnics to improve staff retention, and that was out. Although I had a couple of colleagues who were of like-minded, ex-development workers, ex-Goal, ex-MSF, and we used to have our thrashings out by the seafront when we were allowed, or within the 2 kilometre or so, the fresh air. But one of the things we did in the HSE was coordination is very important. So people are all very busy doing lots of things, but there has to be some level of coordination, so you know your role, you know who's doing what. And in the homeless sector, for example, we asked Dr. Austin O'Carroll to become the Dublin Clinical Homeless COVID lead. What did that mean? It meant that there was some network for all the NGOs supporting homeless, whether it's McVerry Trust Dublin, Simon, DePaul, Crosscare. We had multiple agencies, multiple staff, and multiple fears. So we set up networks to support people within their networks, and then they were able to get their questions asked. And another thing would be to prepare in peacetime. So when you don't have an outbreak, or even when you do, to pick up the pieces and debrief and figure out what you could do better the next time. And also, don't put impossible tasks on people. So in the beginning of COVID, I had to say, look, isolation is not incarceration. We're not locking people up. When the government came to very reluctantly bring in quarantine for incoming travellers, the Department of Children would not use that word for people seeking asylum in this country. So we had what I call supported quarantine, not real quarantine, but supported accommodation where people were supported to keep safe. So I think, not putting impossible tasks, providing support for staff. And the other thing is, we learn as we're doing. I learned that in Malawi. We can make mistakes. We're not meant to be perfect. We pick up the pieces and we'll try to do better next time.
I'm an optimist. So, if there's anything good that came out of the COVID-19 pandemic, it was that people started talking about mental health and well-being. I think health staff have always had quite stressful jobs. Obviously, that was amplified massively during these outbreaks, and very similarly to Margaret's point, I remember some of the psychiatric nurses, who are very few in the whole country in Sierra Leone, didn't see their family for months and months and months because they didn't want to risk, having been on the front line, going home and giving this disease to their families. So they were essentially sleeping at the clinic as well as working all day. And so those impacts are huge. But historically, especially men, people have tended to feel like they shouldn't talk about it. And maybe health workers in general have a kind of a mentality that they're there to serve and they don't want to kind of put their burdens on other people. I think that's really started to change. People have started talking about well-being at an individual level with their colleagues and with their neighbours, and there's practical things that were done in a very organic way in many clinics, setting aside a room where people could go and have tea, which didn't exist before, or flexibility around time, making sure that people were able to get home, sometimes, and all those efforts are really important. And I think we're starting to see that filter much more into organizational level work as well. So, I would say that most companies, now have an explicit well-being policy. There's a deliberate effort to acknowledge this is a part of people's lives, and to an extent, the responsibility of employers to consider that part of people's lives, whereas that hasn't been the case for a very long time, historically, and the population's talking more about mental health, and that's a good thing. There's a lot of talk in my field about a dividend of this increased knowledge and awareness and talking about mental health at kind of national level. We haven't really seen much of an increase in investment in services yet, because they're massively underfunded in lots of countries, and that's a real priority. But definitely the conversations at political levels have changed quite a lot, and there is a sense that we're able to build back better on the basis of the increased attention that was paid to mental health during a pandemic.
Thank you, Julian. And Pamela, I'm going to, I suppose, to come over to you to look at, I suppose we're looking at now a lot of conflicts in the world. The Ukraine obviously is the most, I suppose, current one that we hear a lot about. And obviously, how do people access healthcare during such a crisis? We can send staff over there, we can send products, but really, do we actually think of those who are marginalised as well in conflict zones, and how do we fill their needs, and how do we reach out to them? So, can we do better?
So, thanks for the question. First of all, I just brief comment about the recent conversations that our panelists were having, and then I'll respond to the Ukraine or the conflicts. COVID, in my experience, showed also the historic evidence of how the biggest gaps and inequalities are in this world. And we have to learn from that and not overlook it, but show that inequalities are happening and happened. And not only in our health system and in the response and the readiness, because people would forget about us until the afterwards. So the positive thing is that we now have these evidence that there's this inequality, and now we should start working and building back better, building newer realities, trying to close this gap, close the gap. And that is a challenge for all of us. Now, working together, collaborating means in the healthcare sector, healthcare workers, healthcare professionals, having that liaison and working with the communities, civil societies. Because what our evidence showed, our base investigations have shown that it is important to work with the communities and do those investigations, like in Africa, focus on the deaf women access to health in COVID, during the COVID. And we've had other emergencies there, but what are the barriers? How do we solve these situations? So we have to build on that collaboration with other organizations to improve the systems, because we want to make this change and we want to make it better. So for that, we can't just stay still and have it stagnant. We need to build this, work together to improve the health system in general, to have full inclusion, to have the diversity of humanity, to have working with the poverty, working with indigenous communities, working with everybody. It's because it's a human diversity, and that which we need to focus on. Now, during the humanitarian crisis and the wars, like example, Ukraine, I can't tell you, wow, the responses that we've had and my experiences from our organization, the World Federation for the Deaf. Because, so we have 131 national associate deaf members in 131 countries all over the world. One of our members is Ukraine, the Ukrainian Deaf Association, National Association. And within that, they have different local associations to form the National Association. And then they affiliate with the World Federation for the Deaf. So during this war, the conflict, the war, the deaf were left out. It's like you said, the healthcare system. How are the deaf people able to benefit from knowledge of the services if there's no communication? If a healthcare worker does not even know how to communicate with the deaf community. Right. How can the deaf meet if there's no sign language interpreters or sign language equality? How can there be information? Therefore, when the war started, mental health is a big issue. Information is a big issue. Displacement, people are moving, migrations to other countries, refugees, fear of this war. People are being killed. So the Deaf Association contacted us, asking us for help. They themselves are government supported, and they have 24/7 sign language interpreters in their system as a support system from the government in Ukraine. So they were providing Ukrainian sign language interpreters. However, that was in the country. But if this deaf person was to move to another location, information was cut. And many of these deaf people were migrating as well, closer to countries that were bordering Ukraine. For example, Poland, Hungary. Right, so what do? So the president of the National Association for the Deaf that were neighboring the countries of Ukraine, they all had a meeting, weekly meetings, to see what the crisis was, what's happening in their countries. And we're trying to have these dialogues happening. And so they were saying, oh, in our country we have children, there's no money to send them to school, what have you. So we were finding their needs. And the deaf were communicating within each other, using their own national, and the president had to go and figure out what was happening, right? And meeting the deaf people on site and asking what was happening, because even though they knew deaf Ukrainian sign language, they were communicating within like an international sign language and trying to figure out how to provide all of these services. We're doing also fundraising for Ukraine, for the deaf associations to support them as well, for the refugees, for food banks, information. So right now we're also asking the UN, the United Nations humanitarian or refugees, right? For refugees. We're working with them as well. The blue dots, which means blue dots, which means that there's camps and there's places for refugees to come, and there's camp for them to sleep, and there's health services there, and all of this information is being. However, they're not prepared for the deaf. If a deaf person shows up to the camp, how do they communicate? So we're talking to having them provide blue dots for them to know that those are the dots to follow for a sign language interpreter, because there isn't any. Most of the deaf people who are escaping have no schooling. They don't have no education, and they don't know what to do, where to go. So therefore, we are trying to find these liaisons and working and supporting to help the deaf people. Because people are like, we can provide them with sign language interpreters, but that's not enough. We need to have international cooperation, and we need to have funding so that we can set something up. We can't just go off the cuff. And we try, again, the collaboration, working with business or with other businesses and see what they're doing and what they're willing to set up, video relay services for the deaf or other services. And that's what we're trying to work with right now, currently doing. We're trying to do fundraising for Ukraine, plus we're also trying to meet and, again, trying to establish this collaboration team so that we can continue focusing on healthcare, emergencies, national disasters, humanitarian conflicts. All of these are important issues that we need to talk to, and again, finding these partnerships to try to make sure that they don't leave us behind, because we want to be included in every decision that is happening, and because we're trying to make this transformation.
Pamela. Some great points again there, Pamela. I think you were able to show that, there are some, between a pandemic or a conflict situation, those who are most vulnerable get left behind. They're not taken into consideration from the beginning when it comes to the response, the emergency response, and that going forward, we have seen what's happened during, as you said, the Ukraine there and COVID-19, but we really need to stop that happening again, that you are at the forefront of the response to future crises, that planning is there, that what you need is in place immediately, that it's not just an afterthought, and that, that you're fully involved in the response, because I do think even in Ireland, when you looked at the response to COVID-19, you saw a lot of men in suits. You didn't see equal representation in the response, and it was hard for people to see that their interests were being taken care of too. There's always been inequality in health, but I think the pandemic has really highlighted that inequality. If you were looking at a map on television and every country wanted access to the vaccines first for their people, and it was really sad to see that in parts of the world, whereas the US and Western Europe, we would have had 2-3 doses of a vaccine by the time perhaps parts of Africa had even access to 1 dose. So I think that's really highlighted to people globally how much inequality there really is in health. And also if you look at the Ukraine, whether we keep seeing pictures of weapons being sent to the Ukraine, but at the other side of it, access to basic healthcare, maternity care, cancer care, we're not seeing the money or being spent or the kind of the statements being made about that, how the importance of protecting healthcare services during any type of a war and warning, countries not to attack those services, as opposed to, bland political statements on other items. So I suppose really looking at basic access to healthcare during such a crisis, even when it comes to people coming to Ireland for access to healthcare, it's a struggle, isn't it, to try and just provide what they need. And also then, Julian, I'll come to you to ask about the mental health trauma for people going through such a crisis.
Yeah, thanks. Great insight there from Pamela. I was very privileged to be part of the first response for the Ukraine crisis. So on the 8th of March, when our social inclusion division in the HSE, we have a close relationship with the Department of Children and all those seeking asylum and people coming into direct provision. So we just voted with our feet, because that's part of what we do, which is called barefoot. Our shoe leather epidemiology. We go out to the scene where the action is. We were out at the airport where up to 1,000 people were coming in a day. It was absolute bedlam in the old airport terminal. But that was part of what we wanted to prioritise the medically and the socially vulnerable, the weak, the sick, the hungry, the old, the deaf, people who couldn't, the blind, intellectual disability. And doing that in the middle of chaos was not easy. But I do remember one of the heartwarming things was when a child or an adult, especially a child, came in and the cochlear implants turn off when you're on a flight. So when you come into Dublin Airport, they don't work. And there was absolute panic in some of the parents. How will I get this? How will I get this switched on? What will I do? And then trying to think on your feet. And in fact, Beaumont was fantastic. You could literally send people in a taxi, hope for the best, no English, and come back out again. So yes, it's quite challenging to think of all your groups. But when it comes to the approach for the Ukraine, the principles of the response were very clearly set out. I was asked what my input into that, and I based some of what I learned over many years working with refugees and the UNHCR in Sudan and other countries, which is, build on their own capacity, build to promote resilience, try to get them to preserve their good habits rather than pick up our bad ones, deliver a very acute, prompt response based on basic healthcare, the principles of primary healthcare, and sustainability. So, by and large, and understanding the determinants of health. In other words, delivering health services, running a clinic at the point of entry is not what is needed. We all know with accommodation and shelter and food and support. So knowing our place in the broader scheme of things, and we haven't, and understanding the profile of the country where the people are coming from and the journey they have taken. So some people arrived in very poor condition, having been at the border with Poland for 10 days, and hungry and tired, run out of money, run out of medicines, no diabetic medicines, people with autoimmune disorders, actually getting chickenpox within a week of arriving. So there were, again, understanding that context, what people are bringing, and then what are the basic measures you can do to support them. And doing all that and throwing all that up in the air, it's a toxic mix at times. There's a lot of fighting, a lot of arguing, and but you try to get the fundamental things right. You won't get everything right. And so that's where we call it the art and the science of whether you call it public health or healthcare. It's the cultural, it's appropriate, it's building on what people have. If they have already got expertise or healthcare workers, or participation from the client group is also very important, rather than delivering everything based on the top-down approach. So I hope I haven't taken too much time on that.
That was great insight there. Thank you very much, Margaret. And I suppose, obviously, then, as well as the physical response, we have the response trauma, mental health response. That is obviously crucial as well, and something that often gets forgotten about, I suppose, in the immediate kind of crisis mode that we find ourselves in. Just the importance of mental health response as well for those experiencing trauma in a crisis like what's happening in the Ukraine.
Yes, so I don't know whether you want me to talk about Ukraine itself or migrants into other countries. All the evidence shows that it's the kind of basic needs that Margaret talked about that matter most. I had an interesting conversation with the guy who was kind of running emergency response with FCDO, then DFID, in the UK a while ago, and he was saying to me, as we send our helicopters in, what's the mental health provision you want on the helicopters? And of course the answer was none, actually, because it's much more important that the basic needs are addressed first: shelter, housing, all those kinds of things, food. And that's exactly the same for people who are coming into countries, whether that's across the border from Congo into Uganda, or other places which have had historically huge movements of people, or coming into Europe in this recent Ukraine crisis. It's mainly about whether people can build their lives really quickly and be accepted in. And one of the shameful things about my country is that historically we've treated asylum seekers abysmally. We haven't let them work. We haven't helped them learn language. We haven't let the kids go to school quickly. Now, it's wonderful in a way, the different attitude we've had towards the Ukrainians, but the hypocrisy is incredible. But Ukrainians, have actually been, in my small town in the UK, there's 35 families living with people in the town. And that is a really good example of what can be done, because those kids are going to the local schools, the GPs have been given some extra resources to be able to have those people coming. So that's how it should be done for mental health. Of course, there then needs to be some thinking about how you support people who are struggling, because of course it's a massive trauma, however well things are facilitated for you to get back on your feet quickly. And often that's about helping people have things that are appropriate, language oriented, in terms of language. It can be difficult to find speakers of languages who also have some skills in psychology, very similar to what Pamela's been talking about in terms of sign language interpreters who have mental health skills as well. And finding that combination can be difficult. although the community has really rallied around as well. In a kind of broader sense, there are also needs for building proper mental health services, especially when you have protracted conflicts. So we're doing a project at the moment in DRC, and that's really about finding a way of making sure that the basic services that people would need anywhere else are also available in those very different contexts. People don't have different mental health needs, they just have more of them. So, broadly, prevalence of depression and anxiety double. You have more people who have serious mental health problems as well. And they need services just like anywhere else. So they're harder contexts, but services do need to be built as well. And during crises, the needs tend to go up. So you have to have this capacity to ramp up services just at the time when, as you said earlier, the pressure is to, mental health wards are turned into COVID wards. So that the pressure when you need it most is often actually that mental health, because of a kind of long-standing stigma and deprioritization of mental health, they're often not prioritized.
Thank you. And there is one final topic I was hoping we could cover very briefly, because I know we're coming maybe to the last 10 minutes of our panel discussion. And really, I suppose it's the impact of climate change on healthcare. I think really healthcare really is the area that is the most impacted by climate change, even though we mightn't talk about that enough. We look at now the impact of drought, of heat waves, of tropical storms, and how they impact people's basic survival and their long-term healthcare impacts, even in the UK. There was a very famous case a few years ago about a council being brought to court over the amount of pollution in the air, which led to the death of a child with asthma. So climate change in healthcare, it has been around a long time. It's only in the last couple of years really it is getting the focus it needs. It can be very extreme at the side of drought, but it can also be very much then at the other side of it about the impact of pollution and plastics. And then there is the question of healthcare services. How do we make them more sustainable, less about wastage? Margaret, I'm going to come to you first, really, I suppose, to topic that very broad area, but maybe just a little bit of insight on it.
So many years ago when I first worked in Sudan, it was actually a climate change event. It was a drought and famine in both Ethiopia and Western Darfur, and the desert encroaching on people's land. And we didn't appreciate just how huge that topic would become. And even in the last 5 years in the HSE, one of the projects I really thought was worthwhile was the Department of Energy and Children trying to alleviate energy poverty and improve warmth in people's homes. So something basic like that. And that study is coming to fruition now. It was the analysis done by the London School of Tropical Medicine and Hygiene, looking at health outcomes of older people with respiratory conditions, obviously people in receipt of the fuel allowance, looking at the health outcomes by doing home improvements, insulation, roof, doors, windows, and improving the air quality within the homes. And a significant decrease has been found. But that also, many of us who have worked in any emergencies in the world would just see how unsustainable it is when you see people chopping down the local beautiful forest just for firewood. And in Addis Ababa, many years ago as well, when the Derg fell, people were imprisoned into warehouse. There was 2,000 people in a warehouse, and each family had their own charcoal fire within the warehouse. So how absolutely awful it is to have that much smoke pollution. So I think when it comes to climate change, what we're doing, consuming all the resources in the global north, if you like, and then the impact that is got on the poorest and on the marginalised, I think society has a huge part to play. And within the HSE, I know there's a greater awareness, there's greater involvement now in the cross-sectoral working groups. So it's like health literacy is very important, climate literacy is even more important.
Thank you. So it is such a big area, really, isn't it? We're just scratching the surface there, but it's something that there's, a lot of thought there. And Julian, there's increasing, I suppose, climate change anxiety among the population, really, isn't there? So that is another thing, really, that's come to the fore, particularly in the last couple of years.
Yes, I mean, it is the biggest health and threat to life emergency that we have, and it's getting worse, and is a question of injustice, because it affects people certainly in the global south, but even within countries, people with disabilities, people with other marginalizations are also coming off worse. Yeah, we're just scratching the surface. We're just learning how to the language around mental health, anxiety, and climate change. I think the place that everyone's landed very clearly is that we absolutely must not start diagnosing people who are very legitimately worried about their future as having a mental health problem. So the language is the solastalgia and eco-anxiety and all these words going around, but a real determination to say, actually, we need to stand in solidarity with people who are quite rightly concerned. And if there's anything that we should be more surprised about, it's denial. It's the incapacity of our systems and our leaders to take seriously what their grandchildren are going to go through. We're just starting to get some good research through now. So there's a big study that was done by a team in Bath, in 10 countries, 10,000 young people thinking about their future and their concerns. And a good number of them were saying, I'm making life-changing decisions about whether or not to have children based on what I see happening to our world. The question really is, what can we do about it? What we can't, the conclusion we can't land on is we're going to treat lots of people for anxiety. We need to have a world that's better and different and where people aren't rightly hopeless about their future, but have something to look forward to. And the kind of ideas floating around that are really, people can take a sense of concern about the future in two directions. That can either be hopelessness and kind of despair and giving up and just kind of not doing anything about it, or anger and being furious about what's being done to them, and actually that leading to agency and change. And we are starting to see some protests. I mean, whether you agree or not with throwing things at Van Gogh, we need to see this. We should be furious, and thank goodness for Greta Thunberg, who's said such truths to very powerful people who've generally patronized her, blah, blah, blah. So, we are in a situation, I think, where the solution on the mental health and anxiety worry side is actually the real world changing, and it's not treating people more.
Thank you. I think absolutely. If you haven't seen the film Don't Look Up on Netflix, perhaps check it out. It addresses that topic very well. And finally, Pamela, I suppose coming to you, climate change, it affects all of us. As we know, it affects those who might be most vulnerable the most, unfortunately. So what are your thoughts really on this?
First of all, the word vulnerability or vulnerable. It's not that we are vulnerable. It's that the situation puts it on us. It's not a verb. It's not a verb. It's a character within the person. So the word vulnerable is forced on us to make us vulnerable. We are not vulnerable. So just to clarify that. Now the weather change, the climate change, yes, it's for in the deaf communities, people with disabilities or in general. Of course, we're all the same. We're part of the diversity and it's hitting us. It's hitting us very hard. It's hitting our health, of course, in general. It's hitting everybody. So I just want to elaborate one quick thing, and it's related to climate change. There's data But there's groups and situations of vulnerability, the situations of vulnerability. And in those areas, there's been data collected on those groups? When there's a climate change and it affects, have there been data collected on those people? Have the government thought about maybe doing some data on them? Now, in the, I can't pronounce the word, Haiti, in English, Haiti. In the last few years, there's been a few earthquakes. There's been earthquakes, and the community, the deaf community, have been separated from the family, have lost family members. The deaf community can communicate with them. Perhaps they passed away during the earthquakes, and there's a lot of deaf people who are by themselves, without families, all by themselves, and they grow up alone. So what's happening with them? Where's that data? We don't know anything about them. So we know there's numbers in general, sometimes, not always, but we kind of have an idea of numbers of people with disabilities and number in general. But if we look close into, we don't know, we really don't know how many, what's going on in that area, who's surviving, what's happening. For example, we don't know who needs health services in the deaf community in those situations. Has there been any surveys specifically related to that deaf health services issues, questions? We don't know. There's no surveys. So when we develop data and analyze it, we must have participation. We must have the community participate. Well, we're working with CBN to have deaf leadership taking the role on this and making sure there's participation, action, and research. We need the government and international agencies to focus on them. When there's a climate change, we need to start with the data, because when they're changing now and when they changed before, and if we continue the same path, it's going to be worse. We know that people, as they were mentioning, people in the government make decisions, the decision makers tend to ignore the marginalized people. And it is now time, and it's not that time, at that time to make those decisions and make the changes. So we need to be best prepared, and we need to be ready. And so we're having more floods, more earthquakes, more DRR disasters. So we're having to develop all of these policies for disaster relief, risk reductions, and that's when we need the evidence. That's when we need the policies. That's when we need to be involved. That's when, with that evidence, and you all are all responsible for this. We are all responsible for this. The government is especially responsible for this, to collect these evidence. Where are they? How is this impacting them? Where, how, when, why? Where are these numbers of these groups? We need to make sure that diversity is involved, because we don't have it. We don't know. If we don't know, we don't see. If we don't have this data, then people don't exist. There's no, they don't exist because there's no data. People, there don't exist, then there's no way to improve policy and make changes. So therefore, just to elaborate a little bit, we need not to forget these groups. The deaf community, like in Pakistan, there's been flooding, and they've been asking for the Federation for the Deaf for help, and we're going to help them. And we're responding to all of these needs. So there's a lot of needs, but there's no data. And it's best to have this so that we can make changes.
Thank you so much again, Pamela. And I mean, thank you as well to Julian and Margaret. We have run out of time, but we made some really important points here today. I think it's all about education, information, access to healthcare, but also equal inclusion of everybody, parity of mental health with physical health, the realization that climate change is coming and we really need to deal with it. So many important points. Thank you so much to our panel today for your very important discussion.